and I'm starting the broadcast now.
The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone. Hello and welcome to the Public Health Reports Meet the Author webinar. My name is Frederick Shaw, and I'm the Editor-in-Chief of Public Health Reports, the official journal of the U.S. Public Health Service and the Office of the Surgeon General. The Public Health Reports Meet the Author webinar series is presented to stimulate discussion around current topics in public health, especially those that have been published in the journal. Today's topic is based on an article featured in the March-April 2016 issue of Public Health Reports. Today's webinar is titled The Oral Health Strategic Framework, 2014 to 2017. It will discuss the strategic alignment of HHS operating and staff divisions' resources, programs, and leadership commitments to improve oral health with activities of other federal partners. The presenters will introduce and review the 5 major goal-oriented strategies that are central to the framework, and they'll update stakeholders regarding the current strategy to improve oral health. On behalf of the U.S. Surgeon General Vice Admiral Vivek Murthy, I want to thank the following people who will be speaking at this seminar. First, Rear Admiral Nicholas S. Makridis, DMD, MPH. He's the Chief Dental Officer of the U.S. Public Health Service. Captain Renee W. Josko, DDS, MPH, the Senior Dental Advisor at the Health Resources and Services Administration. Captain Bruce A. Dye, DDS, MPH, a Dental Epidemiology Officer at the National Institutes of Dental and Craniofacial Research. And finally, Captain Gail Cherry Peppers, DDS, MS, Public Health Analyst at the FDA Center for Tobacco Products. Thank you for all of you for joining us today. This and all PHR webinars are archived on the PHR website for future viewing, and a question and answer session will follow today's presentation. If you're interested in seeking 1 credit for certification in public health continuing education practice instruction, you will be given a password at the conclusion of the broadcast, of the webcast. And now it's my pleasure to introduce Rear Admiral Nicholas S. Makridis, Chief Dental Officer of the U.S. Public Health Service. Let us begin our presentation.
Thank you, Dr. Shaw, and welcome to everyone joining us today to listen to our presentation on Oral Health Strategic Framework. Next slide, please. As Dr. Shaw stated earlier, joining me today is Captain Renee Josko from Health Resources and Service Administration, Captain Gail Cherry Peppers from the Food and Drug Administration, Captain Bruce Dye from the National Institute of Craniodental Research. Although listed as a speaker on our flyers, please note that Dr. Lynn Mowden could not join us today as a speaker. Next slide, please. In today's presentation, we will discuss the vision and the rationale for developing the strategic framework. We will be discussing the strategic alignment of the department's resources, programs, and commitment to improve oral health. We will review the 5 major goals outlined in the framework and their associated strategies. Additionally, we will present activities that we believe are unique action items developed by the agencies in fulfillment of these goals and strategies. At the conclusion of this presentation, we will discuss the suggested next steps for improving oral health. Next slide, please. Next slide. Can we go back a slide? Thank you. On May 25, 2000, the Surgeon General, Dr. David Satcher, released the first Surgeon General's report on oral health. This, as many of you know, was a landmark report for the dental community, which brought to light the oral health needs of Americans and affirmed the importance of oral health as it relates to general health and well-being. Since the release of this report, research has suggested relationships between oral health and a variety of medical conditions such as cardiovascular disease, diabetes, adverse birth outcomes, and oral pharyngeal cancers. Next slide. Over the last 15 years, notable progress has been made in the improvement of oral health. Listed on this slide are just some of the successes. More adults are retaining their natural teeth. Fewer children are experiencing untreated tooth decay. Increased utilization of dental sealants for school-age children. More Americans are served by fluoridated water systems. And because of increased awareness of oral pharyngeal cancers, more adults are receiving examinations. Next page. Despite the progress that has been made, challenges still remain. Access to care is a problem for many Americans and is impacted by factors such as geographic distribution of dentists or the absence of an oral health provider in a rural community. Sometimes problems with access is as simple as the patient not being able to schedule an appointment during a regular clinic hour. Another area that requires attention is the integration of dental services into health delivery systems. Historically, our profession, dental care, has been provided in private practice settings, resulting in a very siloed approach to care. Even information sharing platforms are different. Rarely are medical and dental electronic records even compatible. From low-income families to seniors on fixed incomes, the cost of dental care is often prohibitive for many Americans. Unfortunately, there are over 126 million Americans that do not have dental insurance coverage. That's 1 out of 4 Americans. Health literacy still remains a problem, both for patients and for non-dental providers. Next page, slide please. In 2009, Health and Human Services asked the Institute of Medicine to convene a panel to recommend actions that the department could take to improve the state of oral health. In May of 2011, the Institute of Medicine produced the publication Advancing Oral Health in America. This report examined the state of oral health care in our country and provided specific recommendations to improve it. The IOM recommended a number of approaches for Health and Human Services to consider. These approaches were referred to as the New Oral Health Initiative. Below are 10 organizing principles which guided our committee when drafting the framework. The first bullet, establish high-level accountability. Emphasize disease prevention and oral health promotion. Improve oral health literacy and cultural competence. Reduce oral health disparities. Explore new models for payment and delivery of care. Next slide. Enhance the role of non-dental healthcare professionals. Expand oral health research and improve data collection. Promote collaboration among private and public stakeholders. Measure progress towards short-term and long-term goals and objectives. And last, advance the goals and objectives of Healthy People 2020. Next slide. In response to these IOM organizing principles, the Oral Health Coordinating Committee, under the leadership of former U.S. Assistant Surgeon General Rear Admiral Bill Bailey, they developed and authored an oral health strategic framework. The committee is comprised of oral health representatives from the operating and staff divisions of the U.S. Department of Health and Human Services and other federal agencies such as Immigration, Federal Bureau of Prisons, the United States Coast Guard. The committee is charged with providing direction and coordinating a broad spectrum of oral health policy, research, and programs within the United States Public Health Service, across federal agencies, and between the public and private sectors. Next slide, please. At this juncture, I would like to introduce Dr. Renee Joskow, our next presenter, who has played an integral part in developing and authoring the framework. She will discuss the vision and purpose of the framework and discuss goals 1 and 2.
Thank you, Admiral. May I have the next slide, please? So what is the strategic framework? Well, the framework represents the department's oral health vision and commitment to eliminating oral health disparities. The framework builds upon and outlines a strategic alignment of HHS agency resources and approaches addressing oral health, along with and coincident with activities of other federal partners in order to improve oral health. Now, the development and genesis of this oral health framework is in response to recommendations from the two 2011 IOM reports, Advancing Oral Health in America and Improving Access to Oral Health Care for Vulnerable and Underserved Populations, as well as discussion topics covered at the Oral Health Coordinating Committee's 2012 Oral Health Stakeholder Meeting, and all of that in the context of major federal initiatives such as the National Action Plan to Improve Health Literacy, the HHS Action Plan to Reduce Racial and Ethnic Health Disparities, and the HHS National Prevention Strategy. Next slide, please. Well, what are the courses of action? The framework serves as an outline for a comprehensive action plan, and it represents the alignment of federal activities across HHS, as well as efforts to strengthen cross-agency collaboration and provide new avenues for public-private partnerships in order to collectively improve our nation's oral health. Next slide, please. The framework itself serves as a catalyst for increasing the visibility and progress of a national oral health agenda. It exemplifies the ability of HHS and other federal partners to collectively address the nation's oral health concerns and disparities, and each goal plays a unique role in promoting knowledge and awareness, providing treatment and related oral health services, and translating biomedical and behavioral research to both further the science and promote advances into evidence-based practices. The 5 major goals include Goal 1, integrate oral health and primary health care. Goal 2, prevent disease and promote oral health. Goal 3, increase access to oral health care and eliminate disparities. Goal 4, increase the dissemination of oral health information and improve health literacy. And Goal 5, advance oral health in public policy and research. We will discuss each of these in turn. Next slide, please. Goal 1, integrate oral health and primary health care. Well, many Americans experience poor oral health due to lack of access to care. with cost of dental care and lack of dental coverage often being cited as reasons individuals do not seek the necessary dental care. In the current environment, the dental and medical healthcare systems are typically separated, as Admiral Mercredes had mentioned. This includes, though, the education and training environments for health professionals, the provision of team-based clinical services and practice settings, payment systems for care, and the lack of universal interoperability of patient health records. Efforts to integrate oral health and primary care to improve the oral and overall health of the populations we serve are making headway, and innovative models are being developed and tested. So let's look at what some of the strategies are under Goal 1. Next slide, please. One strategy is to advance interprofessional collaborative practice and bidirectional sharing of clinical information to improve overall health outcomes. When we talk about Goal 1 being to integrate oral health and primary care, the committee felt it necessary to emphasize "and" as reflective in this strategy, the idea of being bidirectional, of medical and dental systems working collaboratively and working together. The second strategy is to promote education and training in order to increase knowledge, attitudes, and skills that demonstrate proficiency and competency in oral health among primary care providers. The third strategy is to support the development of policies and practices to reconnect the mouth and the body in order to inform decision-making across all HHS programs and activities. And finally, last strategy is to create programs and support innovation using a systems change approach that facilitates a unified, patient-centered health home. Each of these strategies, as with each of the goals, are a framework for each of the agencies participating in the Oral Health Coordinating Committee to demonstrate the areas that we're working. Frontline primary care clinicians are members of the medical delivery system who are the most likely to see vulnerable and underserved populations with limited or no access to dental services. And similarly, keeping with that bidirectional theme, dental professionals can serve as key players in detecting chronic diseases such as diabetes, hypertension, and hypercholesterolemia in the dental practice. Next slide, please. Of the 18 sample activities included in the framework for Goal 1, I'd like to highlight one of them here. The Health Resources and Services Administration's support of the Integration of Oral Health and Primary Care Practice Initiative and Pilot Project. The initiative was designed and implemented in response to recommendations from both of the aforementioned 2011 IOM reports and strives to improve access for early detection and preventive interventions by expanding oral health clinical competency of primary care clinicians, leading to improved oral health. HRSA invited subject matter experts and professionals from the public and private sectors to join HRSA staff and provide input through facilitated discussions in 3 phases. The first phase included the development of an essential set of core clinical competencies for non-dental primary care providers. And those correlate with a HRSA-provided starter set of 5 domains. The competencies and their domains were designed with 2 considerations in mind. First, that demonstrated competency would have, in fact, the potential to impact the oral health of those we care for. And second, that the adoption of the competencies is doable in the current primary care setting. The second phase of the initiative included a systems approach and analysis to identify the most appropriate entities that are critical to adopting the core oral health clinical competencies into practice. The process included analysis of the level of influence and a prioritization of key sectors with consideration of a coordinated effort to disseminate, educate, and implement the resulting competencies. The third phase of the initiative, which was the largest and involved the most number of people, incorporated topics from the two prior phases in meetings. It included presentations from expert panelists and HRSA-facilitated group discussions of implementation strategies as well as requirements for the translation of that set of core clinical competencies into primary care clinical practice. The follow-on project refers to supplemental funding that HRSA provided to support 3 community health centers in different parts of the country in order to create and evaluate systems-level change required to implement the core clinical competencies and sustain the integration of oral health and primary care practice. Next slide, please. Goal 2, prevent disease and promote oral health. Well, we know prevention works. Preventive interventions and practices can help to reduce the overall need for time or resource-intensive treatment once disease occurs. And Americans are healthier because of preventive efforts such as cost-saving community water fluoridation and dental sealants, which reduce both the prevalence and severity of tooth decay. Under Goal 2, there were 4 strategies that this framework includes to keep us moving in the direction of preventing disease and promoting oral health. Next slide, please. The key strategies for Goal 2 include 2 evidence-based approaches, the delivery of dental sealants in school-based programs, and expanding community water fluoridation. A second strategy is to identify reimbursement strategies and funding streams to enhance the sustainability of prevention programs, including encouraging cooperation between payers and funders in order to magnify the effects of available dollars and, in some cases, limited resources. Third is to coordinate federal efforts focused on strengthening the infrastructure and the capacity at a local, state, and regional level, including oral health programs. Several examples are included in the framework document. And the last strategy under this goal is to explore new clinical and financial models of care for children at high risk for developing caries, such as a risk-based preventive and disease management interventions. I'd like to share 2 action items that represent Goal 2, disease prevention and oral health promotion. Next slide, please. The first is from the Administration for Community Living. They continue to encourage the Aging Services Network to take steps to utilize resources on the AOA Oral Health webpage to promote health and prevent disease for older adults and people with disabilities. Another example references the Indian Health Service Early Childhood Caries Collaborative, which aims to increase the number of American Indian, Alaska Native children from birth to 5 years of age who receive dental sealants. Now, these are just 2 examples of actions taken by Oral Health Coordinating Committee member agencies in support of Goal 2. Next, I'd like to introduce Dr. Gail Cherry Peppers, who will cover Goals 3 and 4.
Hello. I'm going to provide highlights for Goals 3 and 4. Next slide, please. How can we attain and increase access to oral health care and eliminate disparities? Focus on oral health disparities which disproportionately affect low-income or racial and ethnic minority populations. Disparities impact self-esteem as well as the ability to learn. 47 million individuals are living in designated dental shortage areas. address significant barriers for populations with low incomes or living in rural areas, such as those that have additional transportation problems, those have problems locating providers, and numerous other social inequities. Next slide, please. One strategy includes, for Goal 3, includes expanding the number of clinical settings that provide comprehensive oral health care services in federally qualified health centers, school-based health centers, Ryan White HIV/AIDS funded programs, and Indian Health Service funded health programs. Enhance the cadre of oral health care professionals, expand capabilities of existing providers, and promote models that incorporate other clinicians. Improve and enhance knowledge of providers to serve in diverse communities and networks of care. Next slide, please. Maximize resources for health professionals' training and cultural competency. Assist those in community networks connect with a dental home and align dental homes and oral health services for children. Create multiple partnerships that transform care to accommodate our current aging population, and broaden the scope of sex, gender, and racial and ethnic stratified data pertaining to oral health. Next slide, please. Though there are many, I will just mention a few highlights under the action items. For firstly, Substance Abuse and Mental Health Services Administration, or SAMHSA. Improve access to oral health care for people with behavioral health disorders. Provide a structured assessment for single state agencies for substance abuse services, discretionary grantees, as well as other stakeholders on the correlation between oral health and behavioral health. Accommodate oral health in behavioral health settings, and effectively link behavioral health clients to oral health care. Health Resources and Services Administration, or HRSA. Support the delivery of quality, comprehensive oral health services through health center programs. Monitor dental expansion or renovation projects at community health centers. Analyze data to measure increases in access to oral health services. And I'm going to discuss Goal 4, increase the dissemination of oral health information and improve health literacy. Provide information to increase the awareness of the risk factors and preventive methods for oral diseases for patients as well as healthcare providers. Essential messaging is key through numerous channels of communication. Adults with limited health literacy report that they do not know the importance of oral health nor overall general health. So it's very important, as Admiral mentioned, to focus on health literacy. Oral health status should be a part of the overall health history and be readily available to health providers. Next slide, please. Strategies for Goal 4. Enhance data value by making data easier to use for public health decision making through the development of standardized oral health measures and advancement of surveillance. Improve oral health literacy through the use of evidence-based practices and by providing a consistency of oral health messaging to healthcare providers as well as to the public. Next slide, please. Assess the health literacy environment of patient care settings. Integrate a comprehensive health history and behavioral health information into electronic health records. Next slide, please. I'd like to share 2 action items. The first is under the Centers for Medicare and Medicaid Services, CMS. Develop and promote free oral health education materials in both English and Spanish, targeted to a broad patient community. CDC, or Centers of Disease Control, enhance oral health surveillance efforts, provide grants, and work with partners to expand the capacity of oral health departments to implement oral health surveillance. They're also involved in CDC's Tips from the Former Smokers campaign. Next slide, please. Now, the Food and Drug Administration, FDA, is where I work, and we ensure the public has science-based information on drugs, devices, and foods to improve oral health. Utilize multimedia consumer information to provide timely updates to the general public. Educate the public about the health risk of tobacco through the Center of Tobacco Products. Now, though not a part of the original framework, it demonstrates the spirit of progress that we have made. In May of 2016, the U.S. Food and Drug Administration, CTP, finalized a rule extending its authority to all tobacco products, including e-cigarettes, cigars, hookah tobacco, and pipe tobacco, among many others. This historic rule helps implement the Family Smoking Prevention and Tobacco Control Act of 2009. Next slide, please. I'd like to introduce one of our esteemed authors, Captain Bruce Dye, from the National Institute of Dental and Craniofacial Research. Thank you.
Thanks, Gail. Next slide, please. The last major goal the framework encompasses is facilitating oral health through public policy and research. Most diseases or adverse conditions affecting the teeth, mouth, and other craniofacial areas develop from complex interactions of higher-level factors ranging from biological to behavioral and to environmental of origin. Advances in science and health are most often achieved through a continuum of research where knowledge is built upon prior work. Research is not only needed to improve our understanding of the interplay between these higher-level factors, but to also explore more fundamental issues, provide the foundational knowledge needed for more applied or translational science to follow. Advances in technology can also assist us in advancing not only the diagnosis, but the risk of disease as well. Research is essential for addressing questions applicable from patient care to population health, and dissemination of advances and discoveries in a more understandable not only improves the public's understanding, but can facilitate improvements in care by providers and support discussion for policymaking. Next slide, please. We can improve oral health through research by supporting dental and craniofacial research across the entire spectrum of study designs, ranging from clinical trials to large population epidemiologic studies. Implementation research is the study of methods and procedures to promote the incorporation of research findings into routine practice by understanding and working within real-world conditions, rather than trying to control for these conditions, as is often done in clinical research and trials. In addition, other approaches, including efforts related to health informatics and big data research, will promote improvements in dental public health and patient care. There is substantial interest in addressing health disparities, and research is one tool to pursue this. Intervention studies focusing on behavior and community health factors and implementation of elements of evaluation to assess issues ranging from community acceptability, effectiveness are important considerations in the application of multi-level approaches needed to address health disparities. There is also interest in research investigating the impact of more holistic factors, such as environment and community, on health disparities. Next slide, please. Under Goal 5, we have 6 strategies designed to enhance oral health through research and policy. The first strategy is to expand applied research approaches, including behavioral, clinical, and population-based studies, practice-based research, and health services research to improve oral health. Second strategy is to support research and activities that examine the influence of healthcare systems, organizations, reimbursement, and policies on the provision of oral health care, including fostering government and private sector collaboration. Another strategy is to address disparities in oral health through research that fosters engagement of individuals, of families, and communities in developing and sharing solutions and behaviors to meet their unique needs. Next slide, please. Additional strategies are to promote the translation of research findings into practice and to develop policy approaches that support state Medicaid and CHIP programs to move from paying for volume to purchasing value and from treating disease to preventing disease. The final strategy is to evaluate the impact of policy on access to care, oral health services, and quality. It's envisioned that these 5 strategies taken together will identify new knowledge that can facilitate change, leading to improvement in the oral health of our nation. Next slide, please. An example from Goal 5 we have comes from the NIH, the National Institute of Dental and Craniofacial Research. The NIDCR aims to improve oral health through research. NIDCR supports basic and population research are improving the oral health status of many Americans, yet some Americans continue to experience a disproportionate and unacceptable burden of oral disease. In our efforts to reduce or eliminate oral health disparities, the NIDCR recently formed a research consortium and data coordinating center with the award of 10 grants totaling more than $7 million in the first year of funding. Multidisciplinary teams will study the impact of holistic population health and other approaches to take decisive action against oral health disparities in children at multiple levels of influence, including families and neighborhoods and healthcare systems. Next slide, please. This framework represents strategic efforts that will continue to be reviewed and updated by participating federal agencies. Input from oral health stakeholders, including researchers and public health advocates, will be important for this ongoing process as we move forward with the goal of improving oral health for all Americans. Next slide, please. For additional information or discover more about the Oral Health Coordinating Committee, please check out the OHOC website located on the HRSA website and identified here on this slide. Next slide, please. A list of selected resources used to source information presented in this webinar are located on this slide and on the following slide. Next slide, thank you. And next slide. And finally, some selected resources are identified here, including the National Academies, ODPHP, and the NIDCR website. Finally, at the end of the slide presentation is information on how to earn continuing education credit in public health. Thank you.
Okay, well, thank you to our distinguished speakers, Admiral Makritis, Captain Jasko, Captain Cherry Peppers, and Captain Dye. We will now take questions. You may type your question for any of the authors into the chat or question box in the right-hand corner of the screen. You will open the box by pressing the 2 arrows.
Thank you, Dr. Shaw. Our first question is, What are the Oral Health Coordinating Committee short-term goals and long-term goals? Admiral McCready, do you want to address that, please?
Sure. Can you hear me?
I can hear you.
Okay. Great. Thank you. Just unmuted myself here. So we heard Bruce or Captain Dye just speak about sort of the next steps. It appears that this question here is framing it as what are our next steps in regards to our short-term goals and long-term goals. And I suspect for the short term, I would think that another stakeholder meeting should occur in the next 6 months to a year so that we could sit down and analyze the gaps in oral health. And at this juncture, I would think that by then we should have the midterm results of Healthy People 2020 to help guide us. Obviously, with all of this information together, the stakeholder information, the midterm data, we should be able to reassess and update the existing framework. I also think as a midterm goal, we could perhaps request another IOM report to see where oral health has gone since the previous reports. And quite frankly, I think on the long term, we really have to be thinking about 2020 as being the 20th anniversary of the Surgeon General's report and revisit the possibility of having a new report on oral health in America. Thank you, Erin.
Wonderful. Thank you, Admiral. Next question here. Captain Dye, perhaps this one is good for you to answer. Although there has been an overall decrease in dental decay in children, certain vulnerable populations of children have severe early childhood caries. What is the status of NIH research on tooth decay in young children?
Thanks, Erin. The NIDCR supports a broad portfolio to improve the prevention and treatment of dental caries in young children. And we also support foundational basic research ranging from factors affecting core tissue development, like dental enamel, to research ranging from oral microbiome. We also fund population-level research that impacts young children as well. And some of this research, the effectiveness of fluoride varnish, with combinations of other health promotion efforts that we are encouraging, in combination with other delivery models, to include tools that identify children at higher risk for tooth decay, to techniques that improve the oral health knowledge of caregivers. So we do fund a broad research portfolio.
Okay, great. Thank you. Let's see. During the presentation, Captain Josko mentioned that HRSA developed domains and competencies for primary care clinicians to address Goal 1. How can we find out more about those domains and competencies? And a sub-question is also, is there more information available about the healthcare pilot project? Captain Josko?
Sure, I'd be happy to address that. Well, the HRSA effort, the Initiative on Integrating Oral Health in Primary Care Practice, as I mentioned, involved 3 phases, but spanned over a period of a year. And the actual domains, I can tell you right now, the 5 domains are risk assessment, oral health evaluation, preventive interventions, communication and education, and interprofessional collaborative practice. And under each of those domains are specific competencies, with the idea being that those competencies would be applied as appropriately at your particular facility or practice setting. Again, this was meant to be a core or minimal set because we wanted something that would be doable. Let me tell you as well that if you'd like to read more about the domains and the competencies and even more about the process that we used and who the stakeholders were. On the presentation, we have a references section, and the publication is listed in the references section, and it's the Integration of Oral Health in Primary Care Practice report from HRSA. It's also available through the HRSA website, so the reference will be there for you in the presentation section. But to take this one step further, if we may, can take another minute or so, let me give you an idea as to what we were thinking about in terms of these domains and the competencies. So the idea of a risk assessment is that it would identify factors that would impact oral health and overall health. And so one example of a competency might be for the primary care provider to conduct patient-specific oral health risk assessments on each of their patients. So taking all the patients collectively, but to try to identify which of those patients are at elevated risk. So that's one example of the risk assessment. On the oral health evaluation, that is a kind of synthesis of integrating both subjective and objective findings based upon the completion of a focused oral health history and medical history, the risk assessment, and performance of a clinical oral screening. And so one example of a competency for that might be performing the oral health evaluation, linking the patient history, the risk assessment, and the clinical presentation, and then to identify and prioritize strategies to prevent or mitigate risk for oral and systemic diseases. For the preventive intervention domain, our objective there is to recognize options and strategies to address oral health needs that are identified through a comprehensive risk assessment. And one example of a competency would be to implement appropriate patient-centered preventive oral interventions and strategies based upon that individual person's needs. Under communication and education, what we were thinking about is targeting both individuals and groups regarding the relationship between oral and systemic health, addressing health factors for oral health disorders, the effective nutrition, preventive measures, all of that to mitigate risk at both the individual person level as well as at the population level. And so one example of a competency for that primary care clinician would be to provide to the patient or to the patient's family targeted education about the importance of oral health, how to maintain good oral health, but in the context of it considering oral health literacy, nutrition, and that individual patient's perceived oral health barriers. And then finally, to address the last domain and competency, which is that interprofessional collaborative practice, again, we wanted to emphasize that there's shared responsibility and a need for collaboration among the health professionals in the caring of those patients that we all serve, and especially for those who are at risk of oral disorders, again, to improve overall health, because we feel that oral health is essential and integral to overall health. And so one competency might be exchange of meaningful information among the primary healthcare providers and working together as a team to provide high-quality care for the patients based upon those options that are available in the local health delivery, your referral systems, or even your facility itself. In terms of, I don't want to forget, I know part of the question had to do with the pilot project. An outcome from the pilot project is we developed through our cooperative agreement with the National Network for Oral Health Access, and that website is www.nnoha.org. A user's guide for the implementation of the core clinical competencies into clinical practice. The results of the pilot project are incorporated into this user guide that is available at the NOAA website. So I hope that answers that question. Thank you.
Wonderful. Thank you, Captain. Another question, we've gotten a lot of questions on the goals. Admiral McCready, could you elaborate on, of all the goals, which do you feel would be the hardest to accomplish over time?
6.
Oh, excuse me, Dr. McCreadis, you were cut off. Could you address the question again, please?
Okay, I was making a joke there. Of all of the goals here, it would have to be integrate oral health and primary health into primary health care. You know, as I said earlier in the presentation, I think one of the problems we've had historically with the profession is that, you know, we have worked in private practice settings, many oral health providers or private practice dentists, and it appears to me that we're going to have to change the culture of both dental providers and non-dental providers. So we have to do a better job at encouraging dental professionals to work collaboratively with medical professionals, and also it's important to stress the importance of oral health with non-dental professionals. Now, I know that many of the younger graduates in nursing schools and PA schools, and even our physicians in their residencies, are learning about the importance of oral health. But I think we can do a better job, and I think this remains to be a challenge. So I would have to select integrating oral health into primary health care.
Wonderful. Thank you. We're getting a lot of questions about the new trendy topic of e-cigarettes and vapors. Dr. Dye, perhaps you would be appropriate to answer this, Captain. Lately, there's been a fair amount of coverage in the news discussing the increase of e-cigarettes in the U.S., especially with regard to the use of young adults, and a perceived safety that e-cigarettes are often portrayed as a healthier choice or alternative to cigarette smoking. How would you describe the department supporting research on the consequences to oral health and the safety of e-cigarettes? Captain Dye?
Thanks, Erin. This is a good question because it kind of transcends to the goals, Goal 4 and Goal 5, and as Gail had mentioned earlier, the actions by the FDA to earlier authority to regulate tobacco products also includes e-cigarettes. But part of Goal 4 is disseminating information. We know there's really very little information about the safety of the chemicals in the aerosol mixtures that are released by e-cigarettes and how these may impact oral health. So the NIDCR recently developed an initiative to fund a number of grants to investigate the effects of these chemicals from e-cigarettes on oral health. And this funding covers a broad range of studies that are being supported to include both human participants as well as using cell and animal model systems in order to investigate this. This research will offer a valuable insight into the safety of e-cigarettes, and we hope that as they affect the oral microbiome, the immune system, and the ability of the damaged tissues of the oral cavity to heal. So we're hoping to be able to learn new information over the next few years to really help inform us about the safety of these chemicals released from e-cigarettes and vaping. Thanks.
Wonderful. Thank you, Captain Dye. We have a few questions here about the difference between inserting not just oral health into primary care, but vice versa. Dr. Josko, perhaps you can address what about competency training for oral health care providers in primary care and not just for oral health for primary care?
Sure. There is a report out, as we call it, the IPEC, the Interprofessional Education Competencies, and that speaks to all of the different fields and what those competencies would be for interprofessional education and training. Let me give you some examples or specific examples of where agencies within HHS have actually approached this from, as I said, this bi-directional manner. So one, I think, very powerful example is the perinatal and infant consensus statement, and the effort collaboratively was a public-private partnership with ACOG and HHS and other stakeholders who work together to create this consensus statement that looks at how to treat pregnant women during pregnancy, And so one piece of that is the training piece for oral health is there's a guide that is available through, you can get to it through the HRSA website or through the Maternal and Child Oral Health Resource Center that provides, for example, pharmacological considerations for pregnant women. So this is really geared towards the dental practitioner. It could be used by a medical or allied health practitioner, but it helps the dental practitioner thinking about what the pharmacological considerations are. In addition, that document, the guide, has 2 pages just dedicated to the dental professional to bring them up to speed on what the medical concerns or to maintain and promote the health of the pregnant woman. Another example would be our new emphasis over the last few years on interprofessional training grants for Title VII, which for HRSA, for the Health Resources and Services Administration, I'll give you one example, is our predoctoral training grants. The funding for the predoctoral training grants the last few cycles actually has a focus and goal on creating partnerships with these are 2 dental schools and schools of dental hygiene, to create partnerships with non-dental primary healthcare training programs in order to provide both didactic and experiential learning in interprofessional teams. And so many of us have seen that experiential learning environment promotes the uptake of understanding knowledge, skills, and competency across disciplines. And another piece of the new programmatic guidelines are to create partnerships with community-based primary care delivery sites where the trainees would have substantial clinical experience working in an integrated healthcare delivery system. So those are just 2 examples in the current Title VII grants, but also in the broader picture, there are many initiatives currently underway to bring medicine into dentistry and oral health into medical fields.
Wonderful. Thank you for that description of how the 2 are working together. We've got a couple questions here about how to access the free oral health materials, and other than the published version and public health reports, is there a more user-friendly document that we can share with colleagues, distribute, have as reference materials? Where can the materials and the frameworks talked about today be easily accessed? Admiral Recruitis?
Okay.
I'm sorry, Admiral?
Sorry about that. I'm sorry about that. I was just muting myself. Yes, so if you recall in Captain Dye's presentation, there was a reference to the HRSA page, and you can go to www.hirsa.gov/public health clinical oral health OHCC. If you go to the HRSA oral health website, you'll be able to download a PDF document that will have nice images that you can share with colleagues and other oral health professionals.
Wonderful. Thank you. And it's just about 2 o'clock right now. I'm afraid that's all the time we have for questions. We did have a lot of questions presented today, and what we'll do is we will present the questions that were submitted to the group, and then we can post a question and answer FAQ along with the materials that were recorded today. Next slide, please. Dr. Shaw?
Okay, to all the attendees across the country, thank you for joining us today. A special thank you to the speakers and their staffs for their time and contributions to this very important public health topic. I also want to thank Erin Williams for managing this webcast from the Association of Schools and Programs of Public Health. And of course, I want to thank the Office of the Surgeon General. A big thanks to them. A reminder that anyone seeking 1 credit for certification in public health continuing education practice, you will need a password for this credit. The password for this webinar is PROGRESS, P-R-O-G-R-E-S-S, progress. The next slide, please. This brings us to the close of the Public Health Reports Meet the Author webinar. As a reminder, this webinar will be archived on the PHR website at publichealthreports.org for future. Thank you to everyone and good day.